Good afternoon, everyone, and welcome. My name is Amanda Coventry-Barrage, and I'm the Program Coordinator at DWDC. Today, I'm joined by my colleagues, Kelsey Goforth and Melissa Mueller. Today, I'm speaking to you from the traditional territory of many nations, including the Wendat, Haudenosaunee, Anishinaabe, and the Mississaugas of the Credit, located in Toronto and covered by Treaty 13. I acknowledge the legacy of colonialism and the impact it has had on all areas of life for Indigenous people, including healthcare. As part of DWDC's adherence to the values of inclusion and people-centeredness, we're committed to working with and towards recognizing, respecting, and addressing the distinct health needs of Métis, Inuit, First Nations, and Indigenous peoples related to end-of-life and medical assistance in dying. We will continue to work to and listen to and amplify the voices of Indigenous communities in the discussions of end-of-life choices. I'm thrilled to welcome you today to our next session of Regional Spotlight, a series which aims to provide you with more information on how to successfully navigate MAID and your end-of-life care in every province. For today's session, we'll be focusing on the province of Ontario. Before I welcome today's presenters, I'd like to go over a few housekeeping items. Everyone on the call is muted. However, there are opportunities to submit questions. To do so, please type your questions into the question bar on the Zoom side panel, and we will read it out for you at the end. Please try to keep your questions as clear and concise as possible. And while we are going to try to get to as many viewer questions as possible, unfortunately, we may not be able to get to everyone. If you have outstanding questions following the webinar or questions that are quite personal in nature, feel free to contact us at support@dyingwithdignity.ca, and we will follow up with you individually. We're also going to be sending you a post-webinar survey that will pop up on your screen after the webinar. It will give you the opportunity to share your feedback. This session will be recorded, so you'll be able to watch it again later, so there's no need for you to take notes. All right, I am so excited now to introduce our speakers for today. We're going to start with Diane. Diane Gwartz is a nurse practitioner and MAID assessor and provider. Diane graduated from the University of Toronto in 1985 and became a nurse practitioner in 2000. For the past 4 years, Diane has been involved with community MAID work and has provided over 60 assessments and 25 provisions in that time. Diane also has a personal familial connection to MAID, as her own mother had an assisted death in 2018. Okay, that's Diane. And now we have Dr. Gerald Ashe, Jerry Ashe. Dr. Gerald Ashe is a MAID assessor and provider. He's a practicing family physician in Ontario with a special interest in palliative care. His previous experiences with dying and suffering patients ignited a passion in him for the right to die movement. And since Bill C-14's passing, Dr. Ashe has served as a MAID assessor and provider, which he views as an integral part of his family and palliative care practices. All right, let's get it started now. I'm going to pass it over to Melissa, who's going to start now with our interview.
Thank you so much, Amanda, for those introductions, and thank you, Diane and Gerald, for joining us today. I know we have a lot of people that have been eager to listen and attend this webinar. And so to get us started, I'd like to introduce, a little bit more about what inspired you to enter this field as being a MAID assessor and provider. So I'll start with Gerald, if you wanted to share, what inspired you to get involved.
How much time do we have, Melissa? That's a big question.
Mm-hmm.
And really, in my case, goes back almost 50 years to this just coming September when I started medical school. And, since that time, I've been increasingly introduced and slowly introduced to death and dying. In medical school, there wasn't a lot of attention paid to it, surprisingly. And I'm not even sure whether we're doing that now enough. But there was Dr. Kubler-Ross and her 5 stages of grieving. But, short of that, there really wasn't a lot of emphasis on death. The more of the emphasis was on curing people, okay? The deaths were the failures. Then, however, I went into medical practice, and as a family physician, you know, I soon came to realize that there was a lot of suffering that we weren't able to control. And around in the sort of late 70s, I was introduced when I was practicing in Prince Edward Island to a man, Barry DeVeber, who was he was a hematologist from London, Ontario, and he had this great idea of looking after children who were dying. In those days, you couldn't do much to treat leukemia, and was that we palliate these people, that we look after not only their physical needs, but their spiritual and emotional needs. So that was sort of my introduction to palliative care. I then moved to Brockville, Ontario, where I still am, and had some contact with Dr. Balfour Mount out of Montreal, who was really sort of the father of the Canadian palliative care movement. So I became a real believer in palliative care. However, as time went on, I soon realized again that palliative care is great. I absolutely think it is wonderful, but there are times when we're not able to address the suffering of individuals, and often that is emotional suffering. It's physical suffering we're usually fairly good at. So over the years, as I continued my practice, did palliative care, I had 2 or 3 patients who committed suicide, and during their end of life journey, if you will, which really shook me up, to be honest with you. And so sort of in the 2010 era, just before Bill C-14 came out, I decided that I was going to become an advocate for assisted dying. I joined Dying with Dignity and did some speaking engagements. And then after that, of course, Bill C-14 and so on. So that's kind of the truncated version of my 50-year career, if you will.
Thank you so much. And yeah, you've definitely had a long journey to where you are now with MAID and your experience with palliative care. So thank you so much for sharing. Diane, what inspired you to enter this field?
So throughout my nursing career, my priorities have been in terms of choice-based care and also compassionate care. And that's always what's driven me. I actually tried to retire 4.5 years ago from being a nurse practitioner, but I was really crappy at retirement. And so very soon into it, I realized that it was opportunity for me to do things that I hadn't been able to do when I was committed to a full-time practice. And so I actually decided to get involved in MAID as just an assessor because we were traveling quite a bit. And I thought, well, there's probably a need, and that's pretty straightforward. Unfortunately, at that time, there were no providers in the Niagara region where I live, none. And there was about a dozen people who were waiting for assessments. And so I started going out and doing second assessments, but had nothing to offer them. So they'd had an assessment. They were found eligible by me, but there was nobody who would be their primary. So I became a provider so that I could fill that. And there were a couple of other colleagues that also got involved in the same way. One of the boundaries, I guess, or limitations was there was no funding for nurse practitioners, as there continues to be no generalized community funding for nurse practitioners in Ontario. And so for almost 3 years, I worked in the MAID field in the community without any payment, but did do advocacy work with a colleague. And last April of 21, we were able to get funded. But there's 2 positions in all of Ontario funded for nurse practitioners to do this work. And that's very unfortunate and certainly not enough. But I feel very honored and grateful to be able to do this work. It's a privilege to be able to help people through their end of life journey and to be able to ensure that this is a choice for them. In Niagara, you can, the opportunities to have a MAID assisted or an assisted death other than in the community are extremely limited. So basically, if we're not doing it in the community, it's almost not happening. So yeah, so that was kind of my main push to get involved, was just how significant the need was and how compelled I feel to ensure that people have that choice. The fact that my mom also went through that journey almost at the same time reinforced for me that this was something that I wanted to make sure was available.
Thank you for sharing. And yeah, definitely, your personal experience with MAID has, driven your passion to support those with that choice. And it really comes down to the choice and being able to have it. And also, the gaps of access too. So thank you for sharing. Gerald, the next question I can ask you first. So in your experience, is death something that is commonly or openly talked about within the community? So I'm sure with, your years with palliative care and with MAID, what has your experience been like, talking about death in your work?
Well, I've really seen an evolution over the years. I think that just the palliative care movement, of course, started it by discussing the importance of care around death and preparing for death and discussing death. And then the MAID movement after Bill C-14 allowed people to, in some ways, influence how they wanted to die. So that it really has, I think, there's much more discussion about it. I certainly hear it amongst my patients. They know, what I do, so they often will just bring it up, not just when they're sick. They might be quite healthy and younger, but saying, it's great that we're doing that and we're bringing this kind of out of the closet, if you will. It used to be sort of a kind of a hush-hush type of subject, but we're all going to die. We all want to have a good death.
Mm-hmm. Exactly. And what you said is so true. Death is something that some people don't want to talk about. Yeah, it is kind of hush hush and no one wants to really talk about it. But at the end of the day, all of us as humans will, have death, and we've all been impacted by, death in our lives, experiencing a loved one or whomever. So, yeah, it's definitely been evolving. Thank you for sharing your experience. Diane, did you have anything else to add from your experience and talking about death within your community?
Yeah, I think it's very community specific. I would say that in Niagara, where I live, it is not widely spoken about in the healthcare community. I think people have private conversations, but there are still lots and lots of people who we see much too late in their end of life choice process that have not heard anything about end of life options, right? I mean, they've been in palliative care, they've been seen by many specialists, they're on a path, and yet nobody has really opened the door to speak to them. Now, maybe they weren't willing to have that conversation. Maybe the doctors are trying, but that's what they tell us, is nobody told me about this before. It's a shame, really. I think we need to talk more about it. In the family practice work that I have done, I know that even talking about advanced care planning and trying to get people to have the discussions with their family as to what their wishes would be or might be is very, very difficult. And people think that the children don't want to hear about it, and the children think that they shouldn't bring it up to the parents because, their parents won't want to talk about it. And I think we just have to really keep encouraging people to try and have those open conversations. I mean, dying is a part of living. It shouldn't be taboo.
Absolutely. Yeah, I know. I mean, when we get a lot of, requests on people who want to start the conversation of advanced care planning. And it can happen at, any age. Primarily, it's older people who are, preparing for end of life, but it can happen at any time. So it's always important to have those conversations. And I know we have a lot of webinars in regards to how to start those conversations as well, because it can be a hard conversation to have, or family members may not want to talk about it, and the same, they may not want to share it with their children. Children may not want to talk about it with their parents, but at the end of the day, it is a very important conversation to have and to plan for. And this kind of ties into the last question that I had asked, but how, if at all, have discussions surrounding death and dying changed over the past even 5 to 10 years in your experience? Gerald, did you want to add anything at all about that, maybe in the last even 5 years since MAID legislation?
It's pretty dramatic. That 6 years ago we had Bill C-14. So yeah, there's been a remarkable change in just the willingness of people to, once they're sick. But I think the point that Diane brings up is that when people aren't really sick, it is difficult to get that discussion going with patients. And I often try it, and you sort of come up with scenarios, and it kind of really have to be in the situation where the patient is facing some sort of a really serious illness, where you really start digging into things like how they want to be treated. Do they want any curative treatment or even antibiotics or whatever to allow, and they could have a natural death, or do they want to consider having MAID? And a lot of individuals will sort of talk about MAID and start applying for MAID because they kind of want it in a way as a bit of an insurance policy, okay? And I have seen it be very therapeutic in itself. Just the knowledge, once all the paperwork's in order, and you say to the patient, look, you're covered. If you need it, and if things get too difficult, you can give us a call, and you can see the relief at that time.
Absolutely. And we hear a lot from people who've experienced MAID through their family, the relief that it does give the loved one, knowing that this choice is there for them and they have it there for them and laid out. So yes, thank you. Diane, did you have anything you wanted to add from your experience and how the conversations changed in the last 5 years?
Yeah, I think that the whole conversations around paperwork and responsibility, so DNR, POA, substitute decision makers, I think that people understand better now why that becomes important. I think people talk more about the stories of, when those needed to be utilized. And I do think that people are more open to that. Still, lots of people haven't done the work that needs to be done around it, but people seem to know about it. Oh yes, my daughter's my POA. They tell us that, right away. And often people don't really understand what that authority or how that authority comes into play, because of course it doesn't with MAID, and it doesn't if a person is still have capacity, right? But at least people are understanding that is part of the process. I also think there's a lot more conversations, and maybe because it's become more available in my community in the last 5+ years, but there's more conversation about palliative care and especially about hospice. I think that that's, again, another part of end-of-life care options that people often need to ask for, and need to do the work around deciding whether that's what's going to be right for them or not. So those conversations are important. And then certainly the MAID conversations have been happening. And in interesting ways, I saw a patient yesterday who told me they talked to their lawyer about it, and the lawyer told them that they should have a witnessed document that said that they wanted to have an assisted death when their doctor said that their quality of life had deteriorated. So it was very interesting that the lawyer did, interpreted written request as just a note, as opposed to in Ontario, we have the, formal Form A, Clinician Aid A that needs to be signed. And also did not understand that you can't have advance directive as part of your MAID request. But at least the conversation happened. At least, it was an interesting place for that conversation to happen at the lawyers. But I've had several patients who have talked to their lawyers thinking that it should be in their will. And I'm like, well, by the time you activate the will, it's too late for MAID. So really they're not the ones, that's not the place for it, but at least the conversations are happening. So.
Absolutely. A quick follow-up question about, starting the conversation, like as Gerald, you were saying, there are patients that you have that don't want to necessarily talk about end of life planning, and you kind of, ask them gently to see where they're at. In terms of advice for those who are listening in, what kind of advice would you give those to, start those conversations with their loved ones who may not be very receptive to end of life options at the time?
Yeah, well, again, there's the two sort of scenarios. There's the one where you're healthy and well, or maybe you've got some minor illness, hypertension, or you've had coronary artery disease, and you were thinking about, this might be the way that I will someday pass. But nevertheless, those discussions when you're well, I think you really have to kind of force them. So I'm thinking from the perspective of me, force them on your children, okay? Because it's usually your children you're talking with, right? And you say, look, this is what your mother and I have decided, that in the event of A, B, C, D, we do not want, aggressive treatment. Now, that doesn't mean that's going to happen, because people can change their mind, and when you get sick, you might change your mind. But nevertheless, it does get the children in that frame of mind that will make them maybe a little more flexible and malleable later on when their parents get sick. Then there's the issue where someone is sick and has a life-threatening illness, and they're in a lifespan which is going to be quite shortened, which you don't need for MAID, by the way. And so that's totally different. I don't see as much difficulty getting people to talk about it at that stage as I do when they're well.
Diane, did you have anything to add to that with your experience?
Yeah, so I think one of the big issues is when it's not a nuclear family. So, if I want to have the conversation with my children and, everybody comes for dinner and my husband and I are sitting around the table with them, okay, guys, after dinner, we're going to have a little talk, right? That's difficult enough, but, that can happen. When you talk about blended families and families with children who live in different countries, sometimes there's many layers to the family, stepchildren and half children, and children who are no longer communicating with the parents, but have very specific ideas about what they think should or shouldn't happen because maybe they're still talking to their siblings. Those conversations can be really difficult, and I think sometimes it's easier to just very gently and slowly over time, in the situation like Jerry was talking about at the beginning, where you're still young and fairly healthy, just start to lay the groundwork about what, if you have definite ideas about what your end of life choices would be, to start, mentioning different things, just in conversation. I read this book, or I saw this article, or did you hear about this, blah, blah, blah. I think that I would like to have that kind of thing without making it a big announcement and a big commitment, because it often takes people a while to come around to what you're actually saying. And I think it is easier to have those conversations early when people are still well. Jerry was making the point that when people are approaching end of life, it's easier for them to have the conversation. But I find it's often very difficult for the children, because they're still grieving the idea that they're going to lose their parent. And now you're asking me to show support for you doing it before it would happen naturally. And often that's more than what they can cope with. And I think the way many families are structured is that parents really shield the children from their suffering. And it's not always parents and children, certainly, and I'm sure Jerry's had experience, we have assisted deaths with children and their parents are present, and their parents may or not be able to be supportive or have had these conversations with them. Unfortunately, younger people often have intolerable suffering too. But the majority of people are older. And so, yeah, it's often very hard to put that together. I'm going to lose you, and now you're asking me to support you in doing this sooner. I want more time is, kind of the thinking that children often have.
Yes, definitely. These are great, strategies and how to approach, but yeah, everyone is so different. Every family is structured differently, and they're, overall they are, hard conversations to have, but yes, they are needed to have, right? So my next question is, specific in Ontario. Do you have any information? We can start with you, Gerald. Do you have any information on the number of MAID deaths that have taken place in Ontario?
No.
No? Okay.
I do.
I'm with Diane.
Okay, perfect.
We talked and we divided this one up already, because I have all the stats. So in Ontario, the coroner's office actually sends out monthly reports. And so I am on that email list. So get them every month. So that was easy enough, because the reports up to May 31st just came out last week. So in the past 6 years, since MAID has been legalized in Canada, there have been about 11,000 MAID deaths in Ontario. The number of cases so far in 2022, so this was up till the end of May, so not quite half the year, was 1,500. And in the month of May, there were 286. So that, I think that's pretty consistent with the year, how many had been there in the year. So within that, 49% of MAID deaths are at home and 40% are in hospital. And then the others are at alternate locations. It's actually divided exactly evenly in Ontario for male and female, so 50-50. And the average age is 76, with the youngest having been 20 and the eldest having been 114. I didn't even know people lived that long, but I guess that they do. They have the choice. It's nice that they have the choice. 63% were cancer related. Okay. And often people are very curious about what's happening with the natural death not reasonably foreseeable, what those numbers look like. So I pulled those as well. It's basically, if we look at the end of May, it's basically a year since we've been able to do MAID provisions for people who are track 2, because the law wasn't passed until mid-March, and then we have a 90-day assessment period. Okay, so in that first year, there have been 93 cases in Ontario, which actually represents just over about 2.3% of all MAID cases. So it's still a pretty low percentage of people who are accessing assisted death that are within the track 2, or the natural death not reasonably foreseeable category.
Perfect. Thank you. Those are great stats and very accurate. So Yeah, that's great.
That was the easy question.
Yeah, just some stats. So another question I'll ask you, Gerald, first, and then of course, Diane, you can add in. In your experience, what are some common misconceptions about the MAID process?
Well, I think since Bill C7, and just perhaps assuming that the audience understands the distinction between Bill C14 and then Bill C7, but if they don't, it did remove the 10-day waiting period. So a lot of people still feel that there has to be a 10-day waiting period. There doesn't, as long as you have a reasonably foreseeable death. And just to make that clear, that was always a requirement until Bill C7 came into effect, that you had to be on a trajectory towards your death. And that didn't mean a month, 2 months, 6 months, or even 2 or 3 years, but you had to have an illness that was clearly putting you on a trajectory towards death. Whereas now, if your death is not reasonably foreseeable because you have, let's say, a disability like cerebral palsy, you're born with that, then you then can have access to MAID, providing that you have a 90-day waiting period. So the 10-day waiting period is gone. I think there was a misconception, it still is, that you have to be, quotes, terminal. Definitely not the case. You have to be, as I said, on a trajectory towards your death and suffering intolerably. Trying to think of other real misconceptions lately that I can think of. I mean, I think most people, they know you've got to get a couple of doctors to agree to that. So I don't know. What do you think, Diane? Can you think of any other misconceptions there?
So the ones I was thinking of is often find that people, and it's not just their own misconception, they're sometimes advised that they should be waiting until they're ready to have MAID to put in the request. And of course, as assessors and providers, we strongly encourage people to start the process when they would be eligible. So they have the information, they have the time to work through it, and also so the paperwork is done, and then they can take their time deciding when they would like to have their procedure done. But with 63% of MAID cases being cancer related, what I've come recently to, my new mantra is the only thing predictable about cancer is that it's unpredictable. And so, thinking that you can wait until it's the right time and then things are going to fall into place quickly enough is a huge misconception, because it just often people miss the opportunity because of that. And so to go along with that, another misconception is that people need to be at their end of life. I think a lot of people think that, they need to basically be on their deathbed to be eligible. And MAID is all about supporting people who have intolerable suffering. And lots of people suffer immensely well prior to when their natural end of life might be. And people can be eligible months, maybe even years before their body would have gone through its whole process, but they may not want that. I've had many patients who have watched family members die with the same kind of, specifically cancer, but there are other illnesses that do the same thing, so everybody in my family, not mine, this is what people say to me, all the men in my family have had this type of cancer. I watched my dad, my uncle, and my brother all die of this type of cancer. I don't want to go through that. I don't want my family to go through that. And so they make that choice well before the end of life, which is great when you know that you can do that. So that's another misconception, is having to wait to the end of life. And I think one of the other big ones that I often run into is people think that they need to be referred by a physician, or that they need to be in hospital to have MAID, or that they can be admitted to the hospital in order for them to have an assisted death. And there are some areas in the province where people can be admitted to hospital to have their provision, but I think there's probably more areas in the province where that's not an option. The hospitals are just not open to that. And so again, another reason for organizing things early so that we can look at what are the options for people and how do we work around that.
One of the other misconceptions might be that when you sign the document for MAID that you are having MAID, you can change your mind. And some people just die naturally waiting, and that's okay. They had the knowledge that they were not going to have to suffer.
I think actually there's a flip side to that, which I don't know if it's because MAID has gotten so much press lately, but just within the last few weeks, I've had 2 patients who told me that they were eligible for MAID without having had any assessments. Well, actually not that they were eligible. They told me they were going to have MAID and they were going to have it on this day. And I was going to prescribe the medication for them and they would take the pills by themselves and they were going to die. And they had this all worked out. And unfortunately, that's a huge misconception because before we even get started, we got to step way back. And it's hard to develop a relationship when you tell somebody who's absolutely certain about something as significant as their end of life process that unfortunately that's not the way it works, that there are a lot of other steps that need to happen that unfortunately they don't control. Even though this process is about giving control to people, we work within legislation, and we've got to follow our processes. So that's something that has really surprised me. I don't know, Jerry, if you've had any experience with that, but to have had 2 people in such a short period of time.
Yeah, really, I must say I haven't. I've been, but in Rockville, where I live, Eastern Ontario, just east of Kingston, we're very lucky in that we've got a very open hospital to concept of MAID. So it's really, really well understood in the community, I think, and which is wonderful to live in a community where you can have MAID in the hospital, on the palliative care floor, in your home, or whatever. That
is terrific. Probably because you've been such a strong advocate all this time. And I've recently had a couple of patients that we had to move off of, transfer out of palliative care units home to be able to have their provisions. And that's just such an unnecessary complication. But, they needed to be admitted when they needed to be admitted. But really what they wanted for end of life was MAID, and just kind of breaks your heart. Not to mention all the complications in terms of process and arrangements that need to be made unnecessarily. Anyways, that's a sidetrack.
No worries. Thank you so much for those and clearing, some of them up and for everyone. I wanted to just move. I have a couple questions, regarding grief and your experience with grief as MAID providers. So in your work, you most likely experienced grief from patients and their family members. How do you navigate this? And particularly after a death of a patient? Do you do any, follow-up, or what's your experience with, patients following a MAID death or with their family?
Diane?
Do you want me to speak to that first? So yeah, we've actually talked about that in our community as to whether we should be offering some follow-up. I think there's lots of community supports that are available for people. I make myself available to patients, but and their families, but I very rarely hear from them. I think a lot of people are very well supported within their families for grief, but there are a lot of people who also are not. And how individuals manage their grief journey is so individual, and nobody can predict or even suggest what one person should do over another. I generally tell people to take their time and grieve through their own timeline, not to try and avoid the conversations where people say, by now you should be. And also to be careful about getting caught up in the paperwork, because that can be quite overwhelming, feeling like that has to be done immediately. So that can be a big issue. My biggest, concern for people, I think, is that, and I think the next question leads into this as well. Oh no, I was just wanted to raise it in this. Sorry, it's that people really, or families often really need time for self-care after an assisted death. They often have been very involved in caring for and watching their loved one through their suffering and through their disease process, and they've become, primarily a caregiver as opposed to take care of themselves again, because they often haven't been doing anything to take care of themselves. But then they also often have kind of lost what a normal routine is. So not only have they lost their loved one, who may have, when they were well, been part of their daily routine, but they themselves have lost their daily routine because, maybe they wake up in the morning because the person is calling to them, as opposed to waking up on their own routine. They, feed and toilet their loved ones before they have their own breakfast and shower, and trying to navigate what life looks like after, not just the fact that it's an assisted death, but just after the death of the loved one that they've been often so involved in caring, that's another journey. And I do encourage people to take their time and to do it at their own pace.
Absolutely. And, you have had a personal experience as well. Not sure of your role, but I know in my family, we had a personal experience with MAID, and afterwards it was like running a marathon, and at the end it's over and you don't know what to do. You feel exhausted, you feel tired, and then what's next, because during that MAID navigation and taking care of that loved one, your whole life is just focused on that for quite some time. So it's definitely important to have that self-care afterwards and try to get back to I wouldn't say normal, maybe like a new normal or a new journey after.
Yeah. And the other piece about that, which I don't think we talk about at all, and I certainly experienced this myself, is the guilt for the relief that it's over. Mm-hmm. So that doesn't change whether you missed or loved your loved one, but the drain on people as individuals is huge during that time, during that end of life time. And so just the relief that it's over, relief that even the MAID process is over. A lot of times people are really worried about what this is going to look like. Are they going to live long enough to have MAID that they want so badly? Is it really going to be peaceful? Diane said it's calm and peaceful, but is it really going to be? For a lot of people, it's the first time they've seen someone pass, but they've heard, what it can look like. And, and especially if their loved one has been suffering with pain and loss of independence, knowing that that's done is a huge relief. And yet then you feel guilty, because then you think, well, am I actually happy that they died? No, of course I'm not happy that they died, but nobody wanted to be living that way. So it's better for them. And it's, this back and forth seesaw that you do in your brain. And, I say to people, give yourself the time. Again, it's normal. Like, it's okay. Your feelings are your feelings. You have a right to whatever they are.
Mm-hmm. Absolutely. Gerald, did you have anything to add, in your experience?
Well, I think it's sometimes when you're a MAID provider, you don't necessarily get a long-term, any kind of follow-up, long-term follow-up, or even short-term follow-up for that matter. Mm-hmm. Because you were not really the primary physician or the nurse practitioner for that patient. Mm-hmm. The ideal person to do MAID would be either the family doctor or their nurse practitioner, whoever is responsible for the care, because they would then see the longitudinal effect of that on family, etc. We don't get that. Unfortunately, most family docs are too busy, or they just don't want to get involved. Not because they're objecting, but mainly because it's a little bit of extra work and time. So that it's difficult for us. Now, I mentioned our palliative care floor. We do have a grief coordinator. So we're very fortunate in patients that die in palliative care get follow-up for that. But I rarely, and sometimes I'm a bit surprised, I rarely get any follow-up from families of patients who have had MAID, like not even a card or anything. And I remember when I started doing MAID, and it was so new, I used to get cards and thanking me for, I don't know. And I wonder whether that's because, well, maybe it's commonplace, more commonplace. And secondly, they kind of, like, I don't know whether they want to be reminded about me, like it's over, and, I might see them in the community, some of the families, but, we don't talk about that.
Mm-hmm. Thank you. Just to be mindful of time, I know there's a question, are there any resources you've recommended for people experiencing grief in Ontario? One that I'm sure you're both familiar with, and one that we want to share with our supporters as well, is Bridge C14, which is a great organization that provides, compassionate and peer support for those who are going through the MAID process, or are supporting a loved one through the MAID process during and after. So I know that's a great resource, especially when it comes to MAID and support that way. Are there any other resources that you recommended to families who've experienced grief, maybe throughout the MAID process for their families at all, or if they've asked for any resources?
Well, I've had ministers attending the MAID on a number of occasions. So, and it's very clear that they are going to take over that role. But if there is some kind of a spiritual or religious connection, you could always try a minister. I don't know if you try a priest or not. The other thing is, if you have a palliative care organization in your community, I would call them and say, do you have a grief counselor? And, we've got to get it out there. We want to there are some palliative care teams that will not accept MAID. It's quite simple. But I think if people start asking, why are we not doing that? Why can I not get some grief counseling for that? Or, why cannot my loved one get MAID in your hospital? It's going to make them think, at least.
I think Bridge C14 is a really good resource, and it's Ontario based, so that's really helpful. Out west, there's also Bridge for You, which is also online, so it has some good resources in it. Of course, Dying with Dignity's website has tons of good information, and you guys are amazing resources for information. So I think that's great. Lots of communities in Ontario have Wellspring, and they have lots of good programs and supports as well that can support family members. And like Jerry was saying, the palliative care teams, I think it's throughout the province that they're referred to as a PCOT team, palliative care outreach teams, that are funded through the LHINs. And, I think that they can be a good resource, especially if you are already connected with them. And I know in our area, they're kind of linked with hospice, and the hospice has an outreach team as well. And I know that there are social workers. I've actually had a hospice outreach social worker attend one of the provisions that I was at, so that they could support the family member, because he had actively been in care with his social worker, and there was no other family that was present. And so he wanted to have somebody there for him, and the social worker stood in. So yeah, I think that, within the palliative community, there are a fair number of resources. We just need to reach out to them.
Perfect, thank you. So again, just to be mindful of time and, our audience questions, we have a lot coming in and we had a lot prior to the webinar during registration. I wanted to ask, in Ontario, one of the big questions that we got was, how do I begin the request for MAID? What if someone doesn't have a family doctor? How would one request MAID? Gerald, did you want to start?
I can try.
Okay.
Any physician, and probably if you could get hold of a nurse practitioner, would be required by law, or by the College of Physicians and Surgeons of Ontario, to act on a request for information about MAID or referral. So any doctor, if you are visiting a specialist, an oncologist, you might be getting cancer treatment, even though you don't have a family doctor, you can mention, and a lot of oncologists are very supportive of MAID. So that would be one route. There also are MAID coordination services. I think there's a provincial one. There's one for the LIN that I think might require a little bit of technical knowledge to get that number, but maybe Dying with Dignity puts it on their website or something. I don't know. So they will find someone to help you out, or talk to your daughter, your son, your friend, and say, I need help navigating this. Can you see what you can do to help me out and get me into the right, see the right person?
Mm-hmm.
So the provincial phone number for anybody who wants to self-refer or wants to refer a family member is 1-866-286-4023. And that's for anybody in Ontario. And they're like a hotline number. They'll answer questions. So you don't have to just have a referral. You can ask them questions as well. And then they reach out to the communities, the providers and the assessors and providers in the communities. They kind of know who we are and say, we have a referral. Is someone able to contact this patient? So that's the kind of most straightforward way. But physicians and nurse practitioners, others in the community, healthcare professionals, will also sometimes reach out directly to those of us in the community that are actively involved in MAID, and that's fine as well. I've had several patients who referred themselves, their neighbor or their friend or their cousin was a patient of mine, and they say, well, I got your phone number from so-and-so. Are you still doing MAID? Yeah, and then go ahead. Just recently, I've gotten 2 referrals from a cremation service that I've had a relationship with, and people have reached out to them and said that they were interested in finding about MAID, and so they put them in touch with me. So we don't have to have a strict process. This is, one thing in Ontario that's different than most referral systems, where, you have to go through your family doctor, they have to send a letter, and then it can take months or even more than a year to be able to get care. It can be pretty quick, very often people contact the care coordination service or contact us directly, and we're in their home doing an assessment within a day or 2. It's not always that quick, but sometimes it is, and it shouldn't ever be months. We should always be contacting faster than that.
I'm always amazed that I don't get very many referrals from the care coordination service, but do get many referrals from the doctors and nurse practitioners in our area. Again, maybe reflecting it's more open and out there in the city that I live in than the city that you live in, Diane, right?
Just a very quick follow-up, Diane, to the timing of a MAID like navigating the MAID process and putting in a request to the provision. Is there an average, or what would you say would maybe be an average time? Let's say for track 1, so because track 2 is, that 90-day, but if someone were to, make a request for MAID, what would you say is like the average time span from making the request to being approved, I guess?
Oh, well, that's an interesting question, because what I thought you were leading to was when they have the provision, and that's completely up to the patient, right?
Mhm.
And once we get the approval in place, then, it's up to the patient. In terms of a process of approval, sometimes it can be less than a day, a few hours even, depending on what processes we have in place and how urgent the need is. So I was recently at a patient, I got a referral, contacted the family right away, and the daughter said to me, and I said, what kind of timing are you looking at? And the daughter said, well, mom's begging for it yesterday. I said, well, I can't turn the clock back, so I can't do yesterday, but how about if I come tomorrow? And she said, okay, that would be awesome. And I said, is your mom really, is she very unwell? And she said, yes. So I contacted my colleague and said, are you going to be in the area? Can you come and do the second assessment? So she did as well that day. While I was there, the patient was crying and saying, we have to do this right away. You have to do this right away. And she was actually quite upset that I hadn't brought my medications and wasn't going to do it at that moment. She thought I was coming to provide MAID and I was going to do the assessment. And so I went and made a phone call to a nurse in the community that I know, and she told me she could be available the next afternoon. And so from referral to phone call was probably a couple of hours, to assessment was another 24 hours, and it was less than 24 hours to provision. That's not the norm. That's not the average. I would say in most cases, what I hear from colleagues and what I know I do myself is we try to get in to start the assessment process in about within the week. And then it depends on the urgency for the patient. Sometimes they really wanted a lot of information. They're just really not even ready to move forward. And they don't need a second assessment yet. But if they do, then that again would probably be done within the week. And once they've signed their written request, then the paperwork is done. So I would say, within 2 weeks is a perfectly reasonable time frame. But it also depends on availability. So are people around? Is it vacation? Can we coordinate our schedules, right? Sometimes I call the patients and they have so many doctor's appointments that I can't get in for a couple of weeks, because when I'm available is when they're not available, or they've got family visiting, or there's different things happening. Does that sound about right to you, Jerry, in terms of time frame?
It does. We sometimes, or I sometimes, struggle with these sort of acute MAID or emergency procedures where you get a call where somebody, is like dying really, or close to death, but they want MAID. So we do still have the availability of palliative sedation, and that is something that Diane cannot really utilize because you don't work in the hospitals, and I don't think could you start that in the home, Diane? I don't think so. Could you order palliative sedation?
Well, theoretically, except we don't have anybody, our community doesn't support palliative sedation. So, and I'm not their primary provider. I'm not their palliative care provider, right? We'd have to do that through their palliative care person.
Right. So there are some people that just get the feeling that they want to have control and they want to die right at that moment, right when they want it. But if they are dying if they have an anticipated death within a week, let's say, and they're suffering and it's going to be difficult to get everything together, that patient could be sedated. So they're not suffering anymore. And they will have a natural death within 24, 48 hours, maybe 3 days. But the whole idea of last minute MAID, it's not always easy to fulfill that for patients.
Well, an important piece of that is that the patient has to have capacity at the time that we plan for MAID. And, if they lose capacity later, we have the opportunity, if we've had a waiver of final consent, to be able to activate that. But when we meet them, when we talk about MAID, when they make their written request, they have to have capacity to understand what they're asking for. So there are times we get calls from people and their disease process, maybe their medications, have already compromised their capacity, and then palliative sedation is really the only other option for them.
Exactly.
That was going to lead into my other question that I wanted to ask was, in terms of capacity, which definitely is required, during the assessments, and you spoke about the waiver of final consent. So a big question that we get quite a lot is surrounding, advance requests and MAID. And one of the questions we have is, does mental incapacity prevent MAID, even if it is desired in an advance directive before? And then on top of that, if you could just speak about the waiver of final consent as well. Diane, did you want to start?
Sure. So yes, if a person does not have capacity to consent at the time of the assessment, at the time of their Form A, the signing of their written consent, a written request, then they cannot have MAID, even if anything has been documented previously. We refer to that as advance directives, and there's lots of advocacy work going on to try and put that in place in Canada, but at this point, we do not have a process for that. So we do have, again, that, seesaw kind of thing, especially for people with anticipated decline in cognitive function, for example, dementia, or some other neurocognitive issues, where how do you find the right time to request your actual procedure when you're still competent to be able to make that decision, and yet you're feeling well then, but you don't want to wait until it's too long when you're not competent. So the waiver of final consent is a little bit of a buffer there. Waiver of final consent allows people to establish a relationship with their provider. So it's between the patient and the provider of MAID, to say that if they lose capacity between now and a date that is determined as their date of their provision that they're planning to have MAID. So if they lose capacity prior to or on that date, then they are authorizing the provider to go ahead and do MAID without their consent. Again, this has to happen after the Form A has been signed and after the person has been found eligible. So they have to have been assessed by the provider, but that's when this waiver of final consent can be signed, and it has to be between the patient and the person who will administer the medications. So it's not something a patient can do on their own. They can't just say, I give anybody permission to go and do this. It's an agreement between the provider. And so, for example, if providers are going on vacation, then we usually have the backup person also sign a waiver of final consent with the patient, just in case things were to change while they were away.
Perfect. Thank you so much for clarifying and speaking on, advance requests, and as well as, in some cases having the waiver of final consent as, that buffer, that buffer. Another question is that we've got quite a few is, how do I arrange for my procedure to take place in a hospital rather than at home? Have you had experience with patients who've wanted to have their MAID provision at hospital, but weren't necessarily inpatient yet at a hospital?
I have certainly seen lots of sort of different requests about locations other than home. There seems to be some individuals seem to have concern about their partner living in the home after they've died there. And, I think the ideal place to have MAID is in your home and in your bed. with your partner on the bed with you. But nevertheless, there are some people out there who think that that would be difficult for their partner to carry on in the home, or that it might influence selling the home because someone died in the home. But regardless, so I'll tell you what I have done in various. I'm lucky I'm in Brockville, so we have a palliative care unit. So if it's a palliative care patient, we can admit them. Unfortunately, it kind of means an overnight admission, which is, again, unfortunate. It would be nice if they could be with their loved ones for that last evening. Various communities are trying to work on having places where this can take place. I've heard of funeral homes that are starting to allow it, okay? I've done it in my office in the evening when it's closed, the family comes in, and we're able to do it in my office. So those are sort of, and in Toronto, there's a MAID house now where you can be admitted to have MAID. But I still think the ideal place is home.
Mm-hmm.
So in Niagara, you cannot be admitted to hospital for MAID. You can also not have MAID in hospice or in our rehab center. So we are quite limited to options. We did have a retirement home that we were having communications with to be able to have people come and use their respite bed, but they have now chosen not to support that anymore. So that's unfortunate. But we do have this cremation service and a funeral home, both, who are set up with like electronic lazy boy type chairs that they put into a nice small room for us, and we can use that as a facility. I also sometimes encourage people to look at alternate places in their home. So if their partner doesn't want them to pass in the marital bed, then we frequently use lift chairs or comfortable chairs that people are in the family room or den. Also, some families will have like a spare bedroom that they could use. Yesterday, I was at the provision was just beautiful, and they were outside on the back deck. The woman had spent her entire weekend entertaining out there. Everybody had come to visit her, and she just said, "This is where I want to stay," and it was lovely. So I think that people often think hospital is the place to be, but really a lot of our patients are trying to avoid being in hospital, right? They don't have such good experiences from having been in hospital with diagnosis and treatments and things like that. And so I think if we can be creative and look at other options, I think that we are really helping people.
Another question, and then I have one final question after this. So a question that we got a lot was, can I donate my organs after having MAID? So do you need to be at a hospital for organ donation? So have either of you had patients who've had MAID who wished to donate their organs? And if so, what is the best steps for those who may be interested in doing so?
I've had one patient who donated their lungs, and that was early on, just after C14. And at that time, you had to be in a sort of major teaching hospital where you've got the access to the operating room right away to harvest organs. And then, of course, the patient would have to be the right candidate to donate organs. A lot of cancer patients, I don't think they'll accept them. There are age restrictions, but it's certainly something that can be done, and it is through the Trillium Gift of Life program and they support that a lot. I mean, I've had a few patients where and they were in the hospital actually, but where they send somebody into the hospital, they go through the whole hospital record to determine if they are if they're organ donation candidates, and giving the organs, that is. And it's really, it's wonderful. That one case, I mean, I felt it was very rewarding for the wife of that gentleman.
So in Niagara, the only way to get a hospital provision if you're in the community is to have organ donation. So, because it does have to be done in the hospital, as Jerry said. And so I only know of one patient that we've been able to facilitate that for. We have had lots of patients, though, who have done tissue donation because the restrictions on that are much less. And of course, there's a huge need for corneas, for example, and lots of people, including people who have cancer, can be eligible for donating. And that just happens through the funeral home. So that doesn't actually change our process at all. And since I have the statistics in front of me from the earlier question, I will tell you that out of the 11,000 cases of MAID in Ontario in the past 6 years, there's only been 84 organ donations. And that's actually kind of sad in some ways, I guess. But when you consider that the average age is 74 and 75 is the hard line for Trillium, then I guess that's understandable as well.
Perfect. Thank you so much. So a final question, because we are nearing the end of our time here. In your experience as MAID providers, what are the last moments like when providing MAID? Are there any, stories or times when you've given a MAID provision that have stuck out to you when providing MAID, and what was it like? Was there maybe some ceremonies? Was there music playing? You mentioned, Diane, that someone was outside recently. So what is it like as a MAID provider, and what those last moments are like? We can start with Gerald.
Okay, well, that's quite a question. It's unbelievable. I mean, really, I'm always amazed that the individual is able to maintain their sense of humor, dignity, and to have very, very meaningful moments, those last moments with their family, and for someone to be there and witness that is really, as Diane said earlier, it's a gift. It really is such a privilege to understand the resilience of human beings. Here they are, they're going to die, and they are telling a joke. Like, it really, really is remarkable. I think that's the thing that I see all kinds of beautiful things. I've seen a mother with just tender comments, final comments to each of her 8 children, but to make jokes and kid me and try and make me feel a little more comfortable, right? And their family feel more comfortable is pretty amazing. And that, to me, is such a testament to the strength of human nature.
Absolutely. Diane?
I think that one of the things we often kind of perceive is that people at that moment, right towards the end, when it's time, may waffle. And the interesting thing, and I'm sure Jerry would, confirm this, is that people at the time that they're going to be administered the medications are so grateful. They are absolutely definite that this is what they want to do. I have not ever had a person waffle. I've had people say, I wish I didn't have to do this now if I could be well again. But since I will not be well again, yes, please. Because we always ask for consent right before beginning. And people are often so grateful and so relieved and absolutely definite that this is what they want to do. I also think it's important to say that I believe that it is one of the most unselfish acts of love to be there for a family member at the time of MAID. It's to support someone through this process gives us so much from you, to know that you're allowing them to go in peace, even though you are hurting so deeply. So I speak to that, quite frequently with my people. One of the most memorable experiences I had was a gentleman who actually had a living wake right before his provision. So he had a party and everybody talked about how wonderful he was. He had two or three of his friends. He had been a musician, so 2 or 3 of his friends played music, and he sang "My Way," Frank Sinatra, as his last words to everybody. And as soon as he finished the music, he said, "Over to you now, Diane." And that was my cue that he was giving me my final consent to be able to go ahead. I'd also like to just do a quick promo for, I don't know if you can see this, Stephanie Green's book. If anybody wants to know about what the process is like and what families experience and what those, last words and moments are, she does a beautiful job of telling the stories of families who have had assisted deaths in their world. So I think that we could talk for hours, but read Stephanie's book. It tells the story.
Thank you so much. And yeah, I'm sure both of you just sharing those just couple of moments that you've had, that it can be a very beautiful moment and a beautiful time for the patient, but also for their family too, knowing that they are able to go with dignity right to the last moment. And so thank you for what you both do and what you provide, and being able to give those Canadians, those Ontarians, because we're in Ontario, that option and being able to support those families. So thank you so much for what you do. And then of course, thank you so much for coming today and able to take time to, speak to everyone on this webinar today and being able to answer their questions. And I know we had so many other questions. So if there are any questions that people still here would like answered, please feel free to email us at support@dyingwithdignity, and we'd be sure to answer them for you. And so our next webinar will be on August 17th, where we will be speaking to 2 death doulas about their roles and how they support individuals and their families. And so you can go to our website, you can register for that webinar, and of course you can watch any of our previous ones. This webinar, again, is being recorded, so we will be able to post it in the next week or so if you'd like to rewatch it again. And just a quick reminder that a survey will be popping up after this webinar, and so we appreciate all and any feedback that you have from the webinar today. And so once again, thank you so much, Gerald and Diane, for speaking today and sharing your experience. And again, thank you for everything that you do in your field. So I hope you all have a great afternoon. And try to stay out of this heat if you're in Ontario, because it's pretty bad right now. But yeah, thank you so much and take care, everyone.
Nice to meet you, Diane.
You as well.